Okay, so thank you, everybody. Thank you, Jonathan and Harry, for inviting me to speak today. My topic is systemic therapy, which is a huge topic. So I thought, in the interest of time, I would focus primarily on some of the newer concepts that have been coming out in the treatment of advanced disease. Just quickly, my disclosures. So today we've heard a lot about hormone-sensitive disease in the localized state and with some biochemical recurrence in yellow. And I'm going to focus more today on metastatic hormone-sensitive disease and a little bit on castration-resistant disease as well. For years we had docetaxel and then more recently abiraterone and enzalutamide. But by far the most exciting advances have come in the past couple of years as we've started to understand more about cancer biology and targeted therapies, but also as we start to move treatments earlier on into hormone-sensitive disease states where we can have potentially a greater impact on patient outcomes and potentially cure. So first, the treatment of hormone-sensitive disease. In 2015, there were 2 trials of docetaxel in metastatic hormone-sensitive prostate cancer which demonstrated an overall survival benefit. The first study was a charted study, ECOG 3805, where men with metastatic hormone-sensitive prostate cancer were randomized to receive ADT plus or minus docetaxel. The docetaxel was given for 6 cycles without prednisone, I should add, and the endpoint was overall survival. The outcome was even better than any of us could have hoped. You could see that the median survival for the docetaxel arm was 57.6 months versus only 44 months in the ADT alone arm. And as a result, this became very quickly the standard of care for many of us treating patients coming to us with de novo metastatic disease. But the reality in clinic was a little bit different because when you're treating patients with metastatic disease, there's a wide spectrum of what you see. There are some patients who come in with a heavy burden of disease where they may have visceral metastases or multiple bone mets or pain. And then there are patients who may have a couple of rib lesions or very low volume disease where their quality of life isn't really impacted. And so actually taking docetaxel and working it into our clinical flow became complicated. One of the post hoc analyses that they did on the charted trial was looking at high volume versus low volume disease. And you can see that for patients with high volume disease versus low volume disease, there seemed to be a clinical benefit favoring docetaxel for those with high volume disease. Another study that came out at the same time was STAMPEDE. STAMPEDE is actually a huge trial that's looking at multiple arms contemporaneously at the same time. And one of the first arms that they presented was the standard of care versus standard of care plus docetaxel arm, which I'm going to focus on today. It was randomized 2 to 1, and this is what the curve looked like. Similar to the charted patient population, I've pulled out patients with hormone-sensitive metastatic disease, although I should mention that the STAMPEDE trial also looked at patients who did not have metastatic disease. And you can see here that for the metastatic patients, which made up about 61% of the entire population, that there was clearly a benefit, again, leaning for docetaxel versus standard of care alone, which was ADT, with a hazard ratio of 0.73. So that was all fine and good, and we finally started putting docetaxel into clinic. And then just this year, as we got comfortable with chemotherapy, there were 2 more studies looking at abiraterone in almost the same exact space. And these 2 trials also showed an overall survival benefit for patients with metastatic hormone-sensitive prostate cancer. The rationale for trying abiraterone and prednisone in metastatic hormone-sensitive prostate cancer is that androgen deprivation therapy alone doesn't address androgen synthesis by adrenal glands and the prostate cancer cells themselves. We know that abiraterone and prednisone improve overall survival in metastatic castration-resistant disease, and Mary Ellen Taplin and others have shown that if you use abiraterone early in disease in the neoadjuvant setting, that you can actually get a higher incidence of CRs in that setting. And of course, barriers to chemotherapy use in our patient population can be age, poor performance status, comorbidities, and even just patient preference. Many patients, are just grappling with the idea of being diagnosed with cancer, metastatic cancer, let alone having to think about, then being castrated with hormone therapy and adding chemotherapy to the mix. And so the idea of using abiraterone in this setting was clearly attractive. So this was the Latitude study, which Karim Fizazi presented this year at the plenary session at ASCO. And the study was designed to look at high-risk metastatic hormone-sensitive prostate cancer patients. And the way he defined high risk was 2 of the 3 following, either Gleason 8 disease, greater than or equal to 3 bone mets, or visceral disease. Patients were randomized 1-to-1, and they either got abiraterone plus prednisone plus standard of care ADT versus ADT and placebo. Notably, in the early abiraterone studies, in this study and the next one I'm going to show you, they only used prednisone 5 milligrams, whereas in the castration-resistant population, they used prednisone 5 milligrams twice daily. The primary endpoint for this study was overall survival, and they did an interim analysis at 50% of events, and this was what the interim analysis looked like, which then became the final analysis, because there was a very statistically significant 38% risk reduction of death for patients favoring the abiraterone arm. And similarly, there was a 53% risk reduction in radiographic progression for this population as well. I didn't show, in the interest of time, secondary endpoints, but similarly, all the secondary endpoints were improved, including time to PSA, significant skeletal events, chemotherapy, and next treatment. So at the same time, another study, another arm of the STAMPEDE trial was reported by Nick James and the STAMPEDE investigators. And this is just a picture, or cartoon, if you will, of what the STAMPEDE trial looks like. You can see that each line represents a different question versus the standard of care, which is androgen deprivation therapy plus or minus radiation in line A. And so in the yellow shows what this study looked at. They looked at 2 arms contemporaneously. They looked at the standard of care arm from 2011 to 2014 versus androgen deprivation therapy plus abiraterone. The inclusion criteria for STAMPEDE was a little bit more complicated in that not only did it include newly diagnosed metastatic disease, but also newly diagnosed disease that wasn't metastatic. So if you had stage T3, T4, PSA greater than 40, or Gleason 8 to 10 localized disease, you could also be eligible for this trial. About 95% of patients were newly diagnosed. In addition, they looked at relapsing patients, and about 5% of patients were relapsing. And for the patients who were M0, N0, or patients that were node positive M0, in addition to abiraterone, they were offered radiation therapy, and if patients elected to do radiation therapy, then they only had abiraterone for 2 years. The primary outcome measure was overall survival. There was a 1-to-1 randomization, and the target was a hazard ratio of 0.75. And you can see, similar to all the other curves I've shown you today in early metastatic hormone-sensitive disease, that there was a significant survival benefit favoring the abiraterone arm with a 37% improvement. Now, interestingly, as I mentioned, this trial looked at M0 and M1, and when they looked at the 2 arms, they saw that the confidence intervals overlap, and when they did a test for interaction, it was negative. And so this meant that the benefit for abiraterone favored not just the metastatic arm in this population, but also the non-metastatic arm. So how do we choose docetaxel versus abiraterone now in our clinic? There are no direct comparisons that are powered to show us which is better yet, although some are, I'm sure, in development. There was a little bit of overlap between 2011 and 2013, and at ESMO this year, they presented this data for the docetaxel versus abiraterone arm, and there was no significant difference between survival for these, although, again, this wasn't powered or designed to look at that comparison. Also, there were low-grade 3-4 toxicities in both arms. As you might imagine, for the chemotherapy arm, there was a higher incidence of neutropenia, whereas for the abiraterone arm, there was a higher incidence of cardiovascular events and also transaminitis. So how do we choose? I would say that in 2017, it's physician choice based on the availability of the drugs. You know, in some places, abiraterone won't be covered, and also, of course, patient preference. There are some ongoing combination trials in this space which will shed light but also shed confusion, I'm sure, as to how to proceed. They're looking at different anti-androgens, different combinations, and as they begin to report these, I think that patients will have more options. So now I'm going to move forward quickly into the castration-resistant space. I don't want to overlap too much with Dr. Scher. But in thinking about this talk, and as we move hormone therapy earlier into the disease state, we're going to need to think about how we can improve upon hormone therapies as patients become resistant to them. So just recently, just last week actually, there's another hormone therapy called apalutamide. It's an AR antagonist. It works similarly to enzalutamide. And Janssen submitted a new drug application on October 11th based on the phase 3 Spartan results. And the Spartan trial is for patients with castration-resistant disease who do not have evidence of metastases based on conventional imaging. This study was based on phase 1-2 data of apalutamide alone, which was looked at in 3 separate cohorts. The first cohort was the non-metastatic cohort. The next cohort was castration-resistant metastatic but abiraterone naive. And the last cohort in red was metastatic castration-resistant post-abiraterone. And you can see that PSA response was most robust in the non-metastatic space. And interestingly, for prostate cancer, for castration-resistant non-metastatic disease, there isn't actually an approved agent. And so Janssen chose to look at this drug in that space as it was an unmet need. And the trial accrued apalutamide versus placebo with a primary endpoint of metastasis-free survival. We don't have the results, of course, but since they did file a new drug application last week, I think we can assume that the trial was positive. In terms of overall survival benefit, this is the cast of characters that we currently have available for metastatic castration-resistant disease. The ones we use most frequently, I would say, in clinic are abiraterone and enzalutamide up front, but this may change as we move these treatments earlier onto disease states. We know that for these different hormonal therapies that they're limited by intrinsic and acquired resistance, so patients absolutely respond to these drugs, but there are some who don't. About 30% of patients, as demonstrated in the red line, have maybe an initial decline in PSA, but they progress very rapidly. Then there's a cohort of patients in the green that respond very well and have a durable response. And then there's patients that are in the middle where they have an initial response and then over time their PSA starts to drift up over time. And the question is how we can improve outcomes for these patients. What can we add to androgen receptor therapy, or how can we change androgen receptor therapy so that patients respond longer? So the first idea would be sequential therapy. You just sequencing the drugs that we already have, enzalutamide, abiraterone, and we've looked at that. In fact, many groups have looked at that. This is unpublished data. The green lines are patients receiving abiraterone followed by enzalutamide. The blue lines are patients receiving, the green lines are abiraterone followed by enzalutamide. The blue lines are enzalutamide followed by abiraterone, and we're looking at each individual patient and their PSA response. And we compared this with our unpublished data to data published by Brasso, Laureate, Noonan, and you can see that the PSA decline is really between 8 and 20% for these patients. So it's relatively low, and I'll tell you that it tends to be not very durable as well. So another question is, what can we combine with hormonal therapy to improve it? Again, one of the earlier ideas for us was just combining what we have. So we have enzalutamide, we have abiraterone, we also have apalutamide in an investigational setting. And we know from preclinical and clinical data that increased AR copy number occurs in response to androgen depletion by drugs like abiraterone. We also know that there's upregulation of adrenal enzymes trying to synthesize more testosterone in the setting of AR antagonism. And so the concept here was to combine drugs like abiraterone and AR antagonists to try and improve outcomes for our patients. So there are currently 2 phase 3 studies that have completed accrual, and we're waiting for the results. The first one is the Alliance trial, looking at enzalutamide alone versus enzalutamide plus abiraterone. The primary endpoint for this trial will be overall survival. Another trial is the ACES trial. This is a double-blind trial looking at abiraterone with or without apalutamide with a primary endpoint of radiographic progression-free survival. So now, thinking more about what we can combine with AR-targeted therapy and looking at sort of the genomic landscape, it's become clear, and I mean, Anu just showed us all this data with the heterogeneity of tumor cells, that probably we can begin to select patients based on what their tissue profile looks so that we can combine androgen receptor targeted therapy with treatments that are best suited to each individual patient. Phil talked earlier about olaparib. Another pathway that's targetable for prostate cancer is the PI3K pathway. About 50% of patients with metastatic disease have this. And we know from work done by Brett Carver here at Memorial and others that there's a reciprocal feedback between the AR and PI3K pathways, such that if you inhibit one pathway, you activate the other, and vice versa. So a combination of an AR and PI3K directed drug seems very reasonable for a population of patients who have an activated PI3K pathway. This is work done by Johan de Bono and his group that he presented at ESMO in 2016. And I circled the patients with PTEN loss because patients with PTEN loss have an activated PI3K pathway. So if you select for patients that you know have an activated PI3K pathway, and you give them abiraterone as an AR-targeted agent plus or minus a PI3K pathway inhibitor, in this case it's an AKT inhibitor, ipatasertib, you can see that the combination therapy, the median time to radiographic progression was 11.5 months versus abiraterone alone, which is 4.6 months. So ideas like this are exciting moving forward for patients if you can choose them based on their genomic profiling. Also, I know Susan's going to talk today about immunotherapy, but I can't resist just showing this slide and suggesting that immunotherapy may also play a role for these patients. We're not entirely sure what the best profile is or how to select these patients, but in this study, Julie Graf looked at 28 patients who had already progressed on enzalutamide. She continued enzalutamide, and she added a PD-1 inhibitor. And of these 28 patients, there were 5 exceptional responders. We don't know how these patients responded or why they responded. They didn't all have microsatellite instability or mismatch repair, but it's certainly provocative and makes us think that there may be a signal here that we can find over time that may predict which patients do respond to this kind of therapy. And there is currently a phase 3 study, Ambassador 250, looking at enzalutamide plus or minus atezolizumab for patients with metastatic castration-resistant prostate cancer, asking this question. So finally, one other avenue for overcoming resistance to AR-targeted therapies is thinking about some of the ways that patients become resistant to these drugs, which can be the acquisition of mutations over time. The normal androgen receptor has a C-terminal ligand binding domain, and we know that there's a number of point mutations, some of which I think we referred to earlier today, that can confer resistance to specific drugs like enzalutamide, apalutamide, abiraterone. And so there are novel AR-targeted therapies, some of which we currently have in phase 1 trial here at Memorial, that are looking to overcome these specific mutations in patients who have them. There's also a lot of talk about ARV7 splice variants, and this is when the C-terminal ligand binding domain is off the receptor, if you will, or off the protein, and the receptor becomes constitutively activated so the tumor continues to grow. And there are also some AR-targeted therapies that work independent of the ligand binding domain that may have some efficacy as well. And so these are all exciting areas of exploration going forward. So finally, I think the take-home from my talk today would be that timing of these agents, moving very active agents into earlier stages of disease, maybe neoadjuvant, maybe prior to radiation, adjuvant. These are all exciting concepts with a goal of not just improving outcomes, but maybe even affecting cure in patients that would otherwise not be curable. There are a number of treatments, novel drugs and combinations that we're looking at to overcome acquired and intrinsic resistance to AR-targeted therapy. And I think the common theme for all of us today is certainly that genomic profiling and predictive biomarkers are increasingly being used and should be used to select patients most likely to benefit from specific therapies. And so with that, I will end my talk, and thank you.